I think if you have a high demand patient, even if there's some glenoid deformity, these augmented anatomic glenoids can be helpful. I have just some disclosures that are relevant with some of the companies you saw out there that have these type of devices. So the clinical need for this is important. So there's an unacceptably high failure rate if you use non-augmented glenoids in patients with posterior erosion. So these are excellent surgeons, Joe Ionati, Gilles Valls, some of the world's best. Joe Ionati showed 3-fold increase in loosening when there's posterior erosion and you're just using corrective reaming. Gilles Valls showed 21% loosening rate at 6 years. That's terrible. And again, excellent surgeons, poor options, mediocre results. So this Walsh classification, I think we're all familiar with this, but basically when you have those B-type glenoids where you're going to have a subluxation, and then when you start to get erosion like the B2, that's what we're talking about here. And these are pretty common. So multiple studies show somewhere between 15 to 40%. The group at Kaiser, Anshu, Singh, and others have shown that these are more common in younger and male patients and also higher BMI, like stronger patients. So it may have something to do with repetitive trauma or weightlifting or Lord knows what. But the point is, these are typically going to be your active patients. So what are the treatment options? Well, you can just use a standard glenoid. I just showed you that was a terrible idea, so why would you do that? But finite element analysis shows increased posterior stresses. You're basically creating a ramp. That rotator cuff's they're already subluxating. Now you're creating a posterior directed ramp. You think that's going to help your subluxation? No, it is not. They're going to have levering and increased loosening rate, as I just showed you. Jason Ho has showed increased osteolysis around the central peg, which is thought to be a biomarker for early loosening if you have more than 15 degrees of post-op retroversion. And there's really not a lot of clinical data of this technique.